Hello, I'm Dr. Alders, a pulmonary and critical care physician at Keesler Medical Center, and welcome to our mock Code Blue video. Over the last few months, we have been focusing on improving our Code Blue response. In an effort to assist with this, we have gathered some subject matter experts to demonstrate a well-performed code scenario. In this video, you will watch as the team quickly responds to a patient experiencing alarming symptoms and see how their response evolves into a Code Blue as the patient deteriorates. As you watch this video, I ask that you pay attention to the following key pieces of the Code Blue response. First, prompt recognition of the patient emergency and activation of the emergency response system. Second, the fundamentals of basics of life support, including immediate initiation of high-quality chest compressions and early defibrillation. Third, establishing the crucial roles of a code response team, including the team lead role and how that smoothly transitions as more experienced providers arrive. Fourth, team dynamics and closed-loop communication throughout the response. And finally, the algorithmic sequence of this response per advanced life support guidelines. As medical professionals certified in basic and/or advanced life support, each of you are expected to identify an evolving medical emergency, activate the Code Blue system, and immediately initiate appropriate interventions while the code team is en route. We hope that this video will assist you and your team in the development of a high-quality Code Blue response.
Hi, Mr. Smith, I'm going to just go ahead and give a bedside report really quick to your nurse for today. So this is Mr. Smith. He's a 58-year-old VA patient that has had several days of feeling fatigued and short of breath. They saw him in the emergency department, and they're going to take him to the cath lab for a pacemaker. His past medical history includes diabetes. His blood sugars were okay, though. His symptoms resolved in transit. His vital signs in the emergency department were all normal. He was sitting at about 100% on 2 liters nasal cannula. He's got 2 peripheral IVs in the ACs. Any questions? Okay, then. It was nice taking care of you, Mr. Smith.
Good morning, Mr. Smith. My name is Lieutenant Quinn, and this is Senior Airman Nelson. We're your nursing care team. We're going to get you settled in now and get a full set of vital signs. What is your full name and date of birth?
John Smith. My date of birth is 12 November 1962.
Can you tell me where you are right now?
I'm at Keesler Medical Center.
Are you having any shortness of breath or difficulty breathing?
No, not so much.
Are you feeling lightheaded or dizzy?
A little bit.
So right now your heart rate is 41. Sir, do you normally have a low heart rate?
I've never been told that before today.
He's hypotensive.
So, his blood pressure is 82/39, and his heart rate is 41. Airman Nelson, can you please go and tell the charge nurse and call a rapid response at 376-2020 for symptomatic bradycardia and come back with a crash cart?
Yes, ma'am. I will get the charge nurse and bring back the crash cart, as well as call a rapid response at 376-2020.
Thank you. Sir, we are a little concerned about your heart rate right now. Airman Nelson is going to help with getting some pads on your chest, front to back, and we will need to give you a couple medications to bring your heart rate up. Does that sound okay?
Okay.
Hi, I'm the charge nurse today. I called 376-2020 for the RRT to this room. What is going on?
Lieutenant Britt, this is a 58-year-old male from the VA who was transferred earlier today for bradycardia and intake vitals showed hypotension, indicating we are in the ALS symptomatic bradycardia algorithm. Airman Nelson, can you please place the Zoll pads on the patient? Anterior-posterior placement. Right now, we are maintaining the airway, spontaneously breathing with SATs at 98% on 2 liters nasal cannula. We're going to make sure to keep his SATs maintaining greater than 94%. He is on the cardiac monitor, and we're going to cycle his blood pressures. He does have IV access, 2 large bore IVs. Time permitting, we'll get a 12-lead EKG.
Yes, ma'am. I'll obtain an EKG.
Are you experiencing any chest pain?
No chest pain.
Any difficulty breathing?
No, I'm breathing okay. I'm just feeling lightheaded, like I'm going to pass out.
Can you turn on the Zoll? For symptomatic bradycardia, we have 2 options of pacing or administering atropine. Lieutenant Britt, can you draw up 0.5 milligrams of IV atropine? We can give up to a max dose of 3 milligrams.
All right, I'm going to draw up 0.5 milligrams of IV atropine, and let's go ahead and check to make sure these 2 large bore IVs are patent.
ICU Captain Gillard and Airman Chin here for rapid response. Can you tell me what's going on with the patient?
Yes, ma'am. So this is a 58-year-old gentleman. He just transferred from the VA. He just got to our unit a few minutes ago. So we've got the pacer pads on him, the anterior, posterior, and Lieutenant Britt is about to draw up 0.5 milligrams of IV atropine.
Okay, awesome. Thank you so much. I'll take over from here. Before we give any medications, let's go ahead and assign roles. If you could be on my recorder, please. Britt, if you could be on the Zoll and give medications. If you could be airway, please, and chest compressions if need be, okay? So we're going to go ahead and give the 0.5 milligrams of atropine.
I'm going to give the 0.5 milligrams of IV atropine.
So we're just going to give you a medication that's probably going to help your heart rate come up, okay? It might make you feel a little funny.
It's not going to hurt, is it?
No, sir.
0.5 milligrams IV atropine has been given, followed by flush.
Okay, let's go ahead and do a rhythm check. It looks like we have a rhythm change and a pulse check. Do we have a pulse? No pulse. Okay, let's go ahead and begin CPR. Please call code blue 376-2020. We're changing from the bradycardia to cardiac arrest and VFib. Let's go ahead and charge up the Zoll to 200.
Charging the Zoll to 200.
I'm clear, you're clear, everybody clear? Clear. Go ahead and shock. Resume CPR, please. Okay, if you could go ahead and draw 1 milligram of epi, do not give it yet. Please let me know when we've reached 2 minutes.
And I'm not going to give it.
1, 2, 3, 4, 5, 6, 7, 8, 9, 30.
Good chest compressions. Make sure we keep that depth at least to 2.5.
5, 6, 7, 8, 9, 10.
100 to 120.
6, 18, 19, 20, 21, 22, 23, 24,
1 milligram of IV epinephrine is ready.
9,
Okay.
30. 1, 2, 3, 4.
Bernhardt, are we bagging okay?
Doing good.
Beautiful.
We can just get an end title soon.
Awesome. We can go ahead and get that ready.
This zero out.
So I'm going to zero out the end tidal CO2.
8, 9, 30.
Good chest compressions.
And the end tidal CO2 has been zero.
Thank you so much.
Great quality in this CPR.
Time check.
30 seconds till the next pulse and rhythm check.
Thank you.
We have end-tidal level 1.
Awesome. Thank you. I see the end tidal CO2 of 15 indicating good compressions.
Seconds till the pulse and rhythm check.
Okay, let's go ahead and check a rhythm and a pulse check. Do we have a pulse?
We do not have a pulse.
It looks like we're still in VFib. Let's go ahead and resume CPR and continue to charge and shock.
Hey guys, it's Dr. Russo with the code team.
200.
Hey, hang on, sir. We're gonna charge and shock.
Okay.
Go ahead and.
Clear.
I'm clear. You're clear.
Shock delivered. Resume compressions.
Also, if you can go ahead and give that 1 milligram of epi, thank you very much.
Give the 1 milligram of epi.
Hi, sir. So this is a 58-year-old gentleman coming in from the VA. He came in for bradycardia, became symptomatic. We gave 0.5 milligrams of atropine. He then went pulseless and went into VFib, so we went into cardiac arrest VFib. He's been shocked twice and given 1 milligram of epinephrine.
And that was the epi that was just given right
Yes,
now
sir.
when
Correct.
I walked in. Perfect,
Correct.
thanks. Guys, I'm Dr. Russo. I'll be taking over as the code lead. Let's make sure everyone has assigned roles. If you don't mind helping out with the medications, that'd be
sir.
very helpful.
Okay.
Looks like we have a recorder, timekeeper assigned.
Yes.
Please let me know 2 minutes whenever you administer of the electricity.
1 milligram of IV
Perfect, thanks.
have been given.
Perfect. Lieutenant Britt, looks like you're on medications. Or you're on the monitor. She'll be helping with medicines. Perfect, thank you. We have a respiratory therapist on the airway. Do we have an advanced airway in place?
Not yet.
Not yet. We do have end-tidal, and it looks like our end-tidal CO2 is 12, so good quality CPR, guys. Go ahead and obtain an advanced airway. You can obtain an LMA at your convenience, please. And then we have people on compressions as well. You'll notice on your compressions, it looks like our depth and rate are good. Again, maintain that depth at 2 to 2.4. Maintain that rate at 100 to 120. If you're getting tired, please let me know. We have plenty of people to swap out. Captain Gillard, please draw up amiodarone. That will be our next medication that we'll be getting. You can draw up 300 milligrams of amiodarone. Please let me know when you have it ready. We'll give it after the next shock if needed, okay?
Yes, sir.
All right,
300
thank you.
milligrams amiodarone drawn up.
Perfect, thanks. How are we in time since the last shock?
30 seconds till the next pulse.
Perfect. Let's maintain high quality CPR. At the next pulse check and rhythm check, guys, we're going to swap out compressors after that. If it's still a shockable rhythm, we will shock, and then we'll give amiodarone at that time. Any questions? All right, perfect. LMA is in, great. So now we'll do continuous compressions and administer that breath every 6 seconds, if you will.
5 seconds till the next pulse.
Perfect. Continue that CPR. Good. Pause CPR. Pulse check, rhythm check, please. Do we have a pulse?
No, sir.
Our rhythm is still VF on the monitor. Please resume CPR. Charge to 200. Perfect. Continue the CPR while charging. Good. We're charged. Everyone clear. Go ahead and administer the shock. Resume CPR, please. I'll take that amiodarone, 300 milligrams, please. Excellent. Maintain good depth and quality on the CPR, if you don't mind. Depth to 2 to 2.4. Looks like your rate's a little slow. Are you getting tired?
Yes, sir.
All right, swap out compressors right now, please. Thank you. Resume CPR. Depth 2 to 2.4. Rate 100 to 120. Please let me know if you're getting tired. Now's a good time to go through some of the H's and T's, if that's okay with you guys. Hypovolemia. Please administer normal saline. Let's get a pressure bag going and give 1 liter of normal saline. Hypoxemia. Were any issues to suggest hypoxemia?
No, sir. Bagging good.
All right, sounds good. Let's get an ABG. That will give us our oxygen saturation. That'll give us our acidosis, and that'll let us know about the potassium. The glucose was normal on arrival, is that right?
Yes, sir.
Perfect, thank you. That's it for the H's. The T's, tamponade is on the list. If you can obtain an ultrasound for me, have
sir.
cardiology on standby to bring an ultrasound to look to see if there's any tamponade going on.
Yes, sir. Get an ultrasound.
Tension pneumothorax. We have bilateral breath sounds and we're bagging okay.
Yes, sir.
Any resistance at all?
Nothing.
Perfect, thank you. Also on the T's is thrombosis, both pulmonary embolism and coronary thrombosis. It's still on the differential. Assuming we can get ROSC, those will be the next things that we evaluate for, okay? And then toxins. Anything to suggest toxin ingestion? Excess beta blocker, calcium channel blocker, any meds that we know of history-wise?
No, sir.
All right, perfect, thank you. That's it for the H's and T's. Anything to add?
Looks like our end title has increased to 31.
Perfect. Let's go ahead and pause CPR, please. Let's do a pulse check and rhythm check.
A faint pulse.
Okay, good. We've got a pulse. We're now in ROSC, guys. Let's obtain a full set of vitals. Let's get that blood pressure cycling. Looks like our heart rate is 59.
Blood pressure cycling?
Oxygen saturation is 98%. The blood pressure is cycled. It's now 89/48. We're a little hypotensive, but not too far off. Normal saline still being administered or about to be administered with the pressure bag. Good, it's going in right now. That should help things a lot. How are we doing with the airway?
Doing good. You want an ET tube?
Yeah, let's go ahead and obtain a definitive airway with an endotracheal tube, if you don't mind. Now that we've addressed the airway and the perfusion, let's obtain a 12-lead ECG, please. Make sure that we can understand what's going on with this gentleman.
ECG.
Perfect. All right, guys, it looks like he's actually having a STEMI at this point in time. Please call the on-call cardiologist and the cath lab. We're going to get this patient activated for cath lab. Is he responding to commands right now? Doesn't look like he's responding, so we'll consider some targeted temperature management for this gentleman as well. But his first priority is getting to the cath lab and getting this artery open if that's the issue. Any questions?
No, sir.
All right, perfect. Let's get him packaged up, ready to transport if we can. Thanks. Good job, everybody.
Welcome back. Let's review the critical elements of the Code Blue response you just watched. The key areas we recommend you and your team focus on in your Code Blue training include, first, prompt recognition of the patient emergency and activation of the emergency response system. Second, the fundamentals of life support, including immediate initiation of high-quality chest compressions monitored through the use of a chest compression feedback device, and early defibrillation. Third, establishing the crucial roles of a code response team. Fourth, team dynamics and closed-loop communication. And finally, ensuring your team understands and follows advanced life support algorithms. As medical professionals certified in basic and/or advanced life support, each of you are expected to identify an evolving medical emergency, activate the Code Blue system, and immediately initiate appropriate interventions while the code team is en route. We hope that this video assisted you and your team in the development of your high-quality Code Blue response.